Today I want to share some my experience about how to use the OTO'VIEW technique in the endoscopic ear surgery. Can you see my PPT slide?
Yes, we can see.
Yes, okay. So I'm a Dr. Zhaohui from China National Clinical Research Center for Otolaryngological Disease, Beijing. So it's my great honor for me today to share some opinion or experience about the OTO'VIEW technique. So as we all know, the conventional endoscopic ear surgery still have some shortcomings. For example, one-handed operation. So if the doctor do some easy surgery, that's okay for us. The single-handed operation cannot show the obvious shortcoming. But when you do some complex surgery, so the one-handed operation will show some limitation. So you need to stable operation. That's very important for the surgeon to make the good outcome for the operation. The second one is the surgical hemostasis. So the surgical hemostasis is the first the technique you have to master when you want to go far and further in the endoscopic ear surgery. So the surgical hemostasis is very important for us. That requires the patient's different hemostatic techniques. The third one is when the bony grading during the operation that required the original mode is efficient. So when you use a curette or the intermittent draining with the bore, so that need time consuming and the laborious job. The last one is there is still some possible thermal damage problem during the operation. So there's still a couple of the problem we need to address in the conventional endoscopic ear surgery. So the factors that limits the efficiency of endoscopic ear surgery, the incision bleeding, the one-handed operation, the extensive bleeding from the surgical cavity is the most the biggest problem during the operation, the bone draining. So all these four factors are the limitation for the efficiency of the endoscopic ear surgery. So what we can do to make some change? So the change is needed. So the first one, the need for the patient safety, the need for the good surgical experience for the surgeon, the need for the promotion of the endoscopic ear techniques and the training standardization, the need for the innovation. So how to perform the change making. So the first one is we do some change. We use a continuous irrigating surgical pattern. So all these the patterns are the patterns we can use in the conventional endoscopic ear surgeon. We can do some change. We use some continuous irrigating watering in the operation. So these some equipment we can using in the continuous irrigating surgical patterns. So this is some case we can show you how to use the continuous irrigating mode in the endoscopic ear surgery. This is autosclerosis. You can see. So can you see the video?
Yes.
Okay. So this is the surgical cavity under the water. We use continuous irrigating mode during the operation. So if there's some small bleeding, so the continuous watering can flush the bleeding away. You can maintain the surgical cavity clear. So this is the tympanic code, the nerve, and we enter in the middle ear cavity. We show the sclerosis pathology. So in this pattern, you cannot see the shortcoming of the one-handed operation. So you can see there's too much autosclerosis pathology in the anterior part of the middle ear. You just remove them piece by piece. So we curate some bony in the posterior part of the middle ear. We can show the stapes. Here is the incurs and stapes. The incurs, the inferior part of the incurs you can see it has some erosion. So you remove the incurs. This is stapes. So we just remove the residual autosclerosis pathology. So you can still to see some bleeding flush away from the inner part of the middle ear. So this is the orifice of the eustachian tube. So we switch into the non-irrigating, non-continuous irrigation mode. We can construction of the ossicle chain. So we use a cartilage to repair the so we can restore the flap and end up the operation. So this is the continuous irrigating. So the continuous irrigating mode is the basis of the OTO'VIEW technique. So after that, we on the basis of the continuous irrigating surgical mode, we develop some new instruments and equipment. This is the OTO'VIEW plasma technology equipment. We designed some really new plasma tapes. We can use these 4 plasma tapes to perform all kinds of the middle ear surgery. So this is the main equipment. So this is the irrigation seeds for the endoscope. So this is 4 plasma tapes here. So after that, we can start to promote this kind of the OTO'VIEW technique in China. We have made some Chinese experts consultant, and in this year. So this is Chinese experts guidance for the clinical application of the OTO'VIEW technique. We tried out in more than 149 hospitals in China, carried out in the 11 provinces, nearly 4 species OTO'VIEW technique application in the China. So this is the whole equipment. With this equipment, we can perform all kinds of middle ear surgery. So I want to give you a case here. This is inlay laryngoplasty here. You can see here. So you can see the video.
Yes.
Okay. So this is the plasma tapes. We can making the cutting function here. So use this kind of the tapes, you can elevating the flap and stop the bleeding on the same time. So when using this kind of the OTO'VIEW technique equipment, you don't need to worry about the bleeding.
Yes.
Mm-hmm. So the video is frozen, cannot working.
Yes.
Okay, let me get a start. Mm-hmm. Sorry. Okay, let's start. So can the video again, right?
Yes, now it's working.
It's not working?
Working, yeah.
Okay, it's working. Okay. So you can see here, we just elevating the epithelium layer of the tympanic membrane right here. We just leave the fibrous layer in situ. So as you can see here, we don't need to use other surgical instruments, just use these four plasma tapes. We were just reaching to the edge of the tympanic membrane perforation. We will just completely separate the epithelium layer and the fibrous layer apart. And then we use some cartilage membrane lay inside between these layers and restore the epithelium layer and flaps. So this is the end of this operation. So the second case is one patient who undergone traumatic stapes fracture. So this man get a trauma from his child, get the some sticker inside the inner ear, make it staped fall inside into the vestibule. So we got some operation for him. So we elevated the tympanic membrane and entered into the middle ear cavity. So you can see there's some disconnection between the stapes and the incus here. So we drill away some bone on the posterior part of the bone and make clear visualization of the stapes. We curate the last piece of part of the bone. Here you can see there's a very clear stape fracture on the foot plate here, and the foot plate has a fall inside into the vestibule. That's the reason why the patient have a very severe vertigo. So there's a clear fracture on the foot plate here. Oh, you can see here, it's a fracture. So there's a explosion of the vestibule into the in the middle ear cavity. We decided to remove the stapes from the vestibule. So it's just a way we making the autosclerosis with room stape and inserted a piston into the vestibule. So we inserted a piston, established a connection between the tip of the incus and the vestibule. Use a couple of the piece of the fat to seal the vestibule. and replace the flappy. So this is the end of this operation. So another case is facial nerve decompression. This woman got the Ramsey-Hunter syndrome. So we make operation for her. So this is another plasma tapes we can use in the operation. So we drill away some bone on the postal part of the middle ear. You can see here, because this woman has severe sensory neural hearing loss. So we just remove the anchors and cut away the head of the mallards in order to maintain some a good visualization of the operation. Here you can see the horizontal segment of the facial nerve. We use small bore and a lower speed to remove some bony, covering the facial nerve. So for this case, we just need to make a decompression of the facial nerve in the geniculate ganglion part. So we start from the horizontal part of the facial nerve and making forward to the geniculate ganglion. Right here you see we remove some sine bone covering the facial nerve. Very close to the geniculate ganglion. Further drilling away the bone. So we cut off the facial cease to make the final decompression. So before the operation, this woman got facial palsy, about House Blackman 6 degree. So after operation, 4 months later, he got House Blackman 2. So after decompression, we start to repair the middle ear cavity. Because of the woman's sensory neural hearing loss, we don't need to repair the hearing function. We just use a piece of cartilage to repair the epithelium. And replace the flap. So this is the case of the facial nerve decompression. So the last case is about middle ear cholesteatoma. So in this case, we use the OTO'VIEW technique and combine with the keyhole technique. What's the keyhole technique? We just drill a bony keyhole on the posterior part of the bony wall. So through the keyhole, we can inspect the cavity of the mastoid. You can see here, I'll show you how to do that. So this is a posterior part of the canal wall. We drill a keyhole. Through the keyhole, you can see here, this is the lateral semicircular canal, and this area is mastoid. So through the keyhole, we can see the cholesteatoma just limited in the epithelium and middle ear without any involvement of mastoid. It's not working.
It stopped.
Yes, I know. I know.
Now?
No, I will replace it. Sorry. It's working?
Now it's working.
It's not working?
It stopped again.
Or stop again? Okay, I know.
Now it is working.
Working?
Yes.
I started again. So here we can see the cholestoma in the epithelium cavity. We just remove them. So in order to remove all the pathology completely, we have to remove the anchors. After that, we can see there's still some pathology hiding behind the epithelium cavity. So we use Keyhole as another working channel to remove the pathology from the posterior to the anterior. Yes, you can see here.
The bridge.
So if you don't make sure you can remove them completely, you can use the angled endoscope to make some inspection. So after that, we can say we have removed all the pathology completely. We can start to make a construction of the middle ear. So this is keyhole view. You can see here. So we still use the cartilage to make some construction. So use cartilage to repair the epithelium. Place in a pop on the anchors to make the osco chain construction. So as for the keyhole, we also need to make some construction. We use a cartilage. So this is the end of this case. So we use 4 cases to show you how to use the OTO'VIEW technique. So about the issues that OTO'VIEW technology needs to solve. So the perforation system, water flow and pressure control, we have solved this problem. So the improvement in the perfusion endoscopy, we have designed some new endoscope with a perfusion function. Plasma energy control, we have those things, we have addressed this problem as well. So thank you. Hello?
Hello. Many thanks for Professor Hu for his wonderful presentation and very helpful presentation. I am very admired about the videos and I'm very admired about the techniques. Thanks for OTO'VIEW 400 of bonuses who makes the impossible in the ear surgery possible and easy, especially in the hand of professor like Dr. Hu. Do you have any question that would like to consult or discuss with Professor Hu? Please don't hesitate and raise your hand and question and share your good ideas about us with us.
Thank you.
Thank you, Dr. Zhaohui. Thank you, Dr. Hu. I believe that there is a question here from an attendee asking about the working with plasma instruments around the nerve, like the chorda. Is there any risk or damage may happen, Dr. Hu, while using the plasma instruments? This is the question.
Any potential risk for the inner ear?
The question is related to the risk or the damage that may happen.
Damage for the nerve.
Yeah, for the nerves while using the plasma instruments.
So for the plasma technique, we cannot use the plasma tips directly on the nerves. We cannot use that. So when you cutting the flap or remove some pathology, you use the plasma tips. That's okay, but you cannot put the plasma tips directly on the top of, on the surface of the nerve. We cannot use that. That's still risky.
But I think the plasma tips has very low thermal effect, even in the surrounding.
Sorry?
Thermal effect has very low thermal effect on the tissues and the surrounding nerve.
Yes, I think so.
Yeah, exactly. I think the maximum temperature, implemented temperature, maybe maximum 50 or 60, something like that.
We see a very wonderful videos for Dr. Hu elevate the flaps with minimal bleeding and minimal damage to the tissues, comparing to the conventional method.
So for this, for now, we use the we set the index for the minimum energy to cutting or the stop the bleeding using the plasma tips.
Yes, that's great. Another question, Dr. Hu, from an attendee also. The question is, What was the indication for facial nerve decompression? Tympanic segment only in a CSE of facial paralysis due to...
Professor Zhaohui.
Yeah.
Professor Zhaohui, may I join you? I'm
Yeah.
Waleed here. I'm a professor of otolaryngology, and I'm one of the international working group in endoscopic ear surgery, and I'm the secretary of the Pan-African Endoscopic Ear Surgeon Federation. Dr.
Yeah.
Hu, welcome.
You are welcome, Dr. Waleed.
Thank you for your fascinating videos and your for spreading your knowledge about the endoscopic ear surgery. And fortunately, I met all my dear Chinese colleagues in Kyoto last December in the Congress, as you know. But unfortunately, I didn't meet you. My question is about the facial nerve decompression. On my own practice, I only decompress, which is a debatable issue, as you know, of the otologists who are refusing to use the endoscope in otology. I only decompress the tympanic segment, either the precochleariform part or the postcochleariform part, according to the finding that I found in the radiology, in the CT. Either the fracture line or the bony fragment decompress the facial nerve, precochleariform or postcochleariform, so I can reach through the transnatural corridor, which is the external auditory canal. But I'm asking about the indication of tympanic segment facial nerve decompression for a case of facial nerve caused by Ramsay-Hunt syndrome. What was the indication to decompress the nerve at this site?
Thank you for your questions. So for now, when we use the endoscopic ear surgery to make some facial nerve decompression, I just have two kinds of the indication. The first one is Ramsay-Hunt syndrome. So when the patient has a history less than 3 months and get a House Blackman, the facial function more than 5 degrees, and there's no signs to get any recovery, so we just make an operation for the patient. This is the first one indication. Another indication is the bony fracture, the temporal bone fracture. If the patient gets the temporal bone fracture, had a facial nerve, gets the conductive hearing loss, there is some bony fracture damage the horizontal segment of the facial nerve. We just use the endoscopic ear technique to open the epithelium to remove the incurs and make the decompression, and then restore the ossicle chain. That leads to indication for me to make the endoscopic ear surgery for the patient with facial palsy.
Yes, I get it. So if we follow the old theory about the facial nerve decompression of a Kahn-Pales palsy or Ramsay-Hunt, as you say, so I think we all need to decompress all the compartments of the facial nerve from the sternomastoid foramen till the geniculate area, not only the tympanic segment. I agree with you that the indication for decompression of the tympanic segment is the fracture post-traumatic facial nerve decompression. If we found the fracture line suggesting the compressed part of the tympanic segment, but I'm query about the facial nerve decompression for viral origin. If we follow the old theory, I think it's better to decompress all the segments, mastoid and tympanic segment, if we follow this theory, which I think it's debatable now.
So for the first one indication were the two indication. The fracture was the Hunter syndrome. Which one you have some question? So doctor,
the question is about the facial nerve decompression of viral origin, either the Kahn-Pales or Ramsay-Hunt. Do you need to decompress the tympanic and mastoid segment or only the tympanic segment?
So what you mean is for the Hunter syndrome, you need to make the decompression for the whole range of the facial nerve, right? It's not just limited in the geniculate ganglion, right?
Yes, that's
Asking
what
about
I mean.
Okay.
decompression
So we
of
have
the tympanic cartilage and geniculate, not from the geniculate downward.
So
The whole nerve.
we make some clinical trial for the Hunter syndrome. One group is just make a decompression on the geniculate ganglion. Another group is a whole range of the facial nerve. But for these two groups, there's no a difference between these two groups. So after that, we just make a decompression just around the geniculate ganglion, not for all the range of the facial nerve. That's my answer.
It's a great point, Professor Zhou. It's a great point. Thanks.
Thank you.
Any further questions?
I think there is another question from Dr. Muhammad Al-Qadi. Dr. Qadi, please, can you open your mic to ask your question, please?
Hello?
Dr. Qadi, Dr. Muhammad.
Hello, doctor. Yes,
Hello.
yes, can you hear me?
Yes, I can hear you.
Yeah, thank you, doctor, for this amazing presentation about this technology. My question is about the value of using this device in dissecting the lateral skull-based tumors. And I have another question about what about working on the auricular with this device? Thank you very much.
I can't hear you. I can't hear your questions. Sorry.
Dr. Muhammad, repeat, please, because the voice is...
There are some cuts off, Dr. Qadi.
Yeah,
so
okay.
Can you repeat your question, please?
Yes. Yeah, Professor, can you hear me now?
Yes.
we can hear you.
Can you say it again?
Yeah, my question is about the what is the value of using this device in dissecting the lateral skull-based tumors? This is the first question. Yeah, Professor, did you hear the question?
Yes. So
Yeah, okay.
okay.
Yeah, the second one is what about working on the auricular cartilage if I wanna auriculoplasty or a harvest? Is it safe to work on the auricular cartilage with it or not?
I cannot get your point of the second question. Sorry.
Okay, I wrote the question and the question list so that I think that you can read it, because I don't know, maybe I have a not good connection, but I wrote the questions already.
He asking if we can use this OTO'VIEW forehand in the section of lateral skull-based tumors, and we can use it in the auricular cartilage.
Exactly.
小宋他什么意思？他说的是什么意思？小宋，你帮我翻译一下。
Hello, Mr. Pasala. Can you
Yeah.
me okay, explain the discussion from Dr. Muhammad for this question?
Actually, the first question, Lina, was regarding the
section. Using
exactly.
the plasma four-handed in dissecting lateral skull-based tumors.
Exactly.
Four-handed. Is that four-handed, right?
The four hands of OTO'VIEW for bonuses. We can use it in the section of lateral skull-based tumor.
我没明白这什么意思，小宋。
We can use the instrument for the section of lateral skull-based tumor, like elevating the flaps.
Yes, we use the plasma tips to do some tympanic tumor or paraganglion, the tympanic paraganglion leomers in the middle ear cavity. We use the plasma tips to do this kind of the operation before. But for the small tumor in the middle ear, if you can clear to see the edge of the tumor, you use the plasma tips to make the tumor size smaller and smaller, and you cut the tumor from the basis on the outer surface of the cochlea and remove the tumor fully, completely. So that's okay.
This is
for
okay.
this kind of the technique. We have a lot of colleagues in China have shown this kind of the operation on different conference. That's okay, totally okay.
The second part was using this plasma tips or in the cartilage, in auricular cartilage.
Cartilage? Cartilage. So cutting cartilage using this kind of plasma tips.
Yes. Yeah, the question about the cutting.
I don't use the plasma tips to cut the cartilage before. I have no the experience. So I can use that to try. If I have any feedback, I will show you. I will tell you. Okay.
Yeah. Okay, Professor. Thank you very much. The question is not only about the cutting the cartilage, it's also related to dissecting the skin flap and the perichondrium from the cartilage. Is this a harm for the cartilage or no? I hope that I will get the response from your side about this.
So we have seen some different cases in the nasal cavity operation from other colleagues. They use plasma tips to cut the cartilage in the nasal cavity. That's totally okay. I have saw that the cases. Yes, okay.
Thank you very much. I have a request for the scientific committee in the company. I don't know is it available or not. A hand for dissecting the tumors of the nasal cavity. Yeah, is it available in Egypt or not?
Okay, Dr. Adi, we will get back to the company scientific committee asking about this point, and I will get back to you very soon.
Yes.
Yeah, thank you very much. Thank you very much.
Thank you for attending, Dr. Adi. Thank you.
Thank you.
Any other question?
那没有问题，小宋就结束吧，你跟他说一下。
I think we reached the finish.
Yes.
Thank you.
For more questions, you can leave message to me. Then we will correct all the questions and contact with Dr. Ho for the explanation. Thank you. So Dr.
Thank you very much. Thank you very much for my call for my friends.
Having experienced such a lively exchange and discussion all over the further understanding of ENT surgery, especially with the OTO'VIEW techniques. Now our discussion is approaching to the end. Thanks for Professor Hu for his presentation. Thanks for everyone. Thanks for Lina. Thank you for the audience. I believe that will be a meeting. That will be a meet time for many times to explore OTO'VIEW with the other advanced ENT surgery techniques. Thank you for all.
So I hope we get a chance, some chance to invite you guys to China. We have a chance to make some deeper communication and discussion further. Okay.
Okay.
Welcome to China.
Yes, I will. Welcome.
Okay. Okay.
Thank you.
Bye.
Thank you. Thank you. Bye bye. See you.
Bye.
See you all.
Okay. Bye bye.
Bye.
好主任辛苦了。
拜拜，拜拜，宋。拜拜，宋。
谢谢。 Thank you, Dr. Shaki. Thank you.
Thank you, Lynn. Bye.
Thank you, Dr. Mohammed. Thank you for joining. Thank you. Thank you all. Thank you, doctors. 结束了，你这个是归并的，研讨会吗？结束吧，结束吧。